South Africa's increase in COVID-19 infections is being driven by the new Omicron variant. It's also spreading in 20 other countries. Scientists are working around the clock to collate data on the new variant. It's unclear whether previous infection with COVID-19 will protect against Omicron, but it's still believed the vaccination will prevent severe illness. To discuss all this further, we're joined by Professor Shabir Madhi and Professor Sanne from Wits University and Professor Bruce Mellado from the Gauteng Premier's Advisory Committee on COVID-19. Thank you very much, gentlemen, for joining us this evening for this panel discussion on something that is still going to seemingly plague us for a time ahead. So best to understand it properly. Now, hindsight is 2020. So given all the knowledge that we now, after 2 years, have about the virus, how it behaves, its subsequent variants and mutations, what were we dealing with at the start of COVID-19 almost 2 years ago? And I'd like to start with you, Professor Sanne.
Thank you very much. I believe that we saw a major antigen shift in the coronavirus at the beginning of this pandemic. We had seen a previous SARS virus, perhaps 8 years previous to that, in the Middle Eastern outbreak. But this one, in fact, was another big jump and indeed was distributed very rapidly around the world, leading to significant transmission rates. Since then, it is an RNA virus that indeed moves with genetic changes all the time, leading to variants. There has been variant surveillance around the world, and this is reported into open databases that are accessible to everyone. We do have then a classification from the WHO for variant of interest, which is a significant change where something is monitored, and then variant of concern. And the important ones to date for South Africa have been the Wuhan virus originally, then the Alpha, then the Beta, then the Delta, and now the Omicron, which is a variant of concern.
Professor Mellado, coming to you. So of all these different mutations or variants over the past 2 years, have different characteristics, they've got different levels of severity and infectiousness. Have the mutations or the changes in the structure of the virus followed a common trajectory, or are they seemingly random?
But first of all, thanks for having me here. So from the modeling standpoint, I'm a mathematical modeler and a data scientist. What we do is we gather as much information as possible from experts, from the literature, from international experts and national experts as to how does a virus look like, how it is expected to behave. Now, what we have seen over the past 2 years, and in particular during the third and now the fourth wave, as we've already been warned by experts that we can plan, we can do modeling, we can do beautiful mathematics, but if something new comes along, then you better be ready to adapt your modeling to the new reality. And that's essentially what's happened during the third and the fourth waves. The experience we accumulated during the third wave, if you remember, around about mid-June, we saw an unexpected acceleration in community transmission, which later, about 10 days later, was attributed to the Delta variant taking over and displacing the then dominant variant. We basically had a plan to basically say, well, we have a bunch of mathematical models, let's simplify them so that we could adapt them very quickly to the new reality, so that we could answer questions that policymakers ask, within an hour of something happening. Are we facing a catastrophe? Do we have enough beds? So you have to react extremely quickly. We learned a lot from the third wave, and what's happened now is extremely similar. We have the advent of a new variant that displaced the Delta variant extremely quickly, more quickly than the Delta variant displaced the previous one. And we basically followed a similar methodology in order to be able to answer the question that was asked to us almost immediately by the Office of the Premier. Do we have enough beds? Where are we going? And so far, it looks like the data seems to be reasonably well described by this dynamic modeling.
Professor Madhi, it's only been a week since South African scientists shared the news of Omicron with the world, and we know it's still going to take a lot more time to better understand this variant. But what do we know so far in terms of its infectiousness, its severity, its transmissibility, and what the modeling says about what we're likely to see in this fourth wave?
Yeah, so good evening. So as Prof. Mellado mentioned, this variant seems to be much more transmissible than what we experienced in the past. But at the same time, I think we need to be careful in terms of extrapolating from past experience. This current resurgence is taking place across in Gauteng right now and will likely spread across the country very soon. It's taking place against a very different backdrop compared to when previous variants arose. And the major difference is there's a large level of population immunity because of past infection, as well as because of vaccination. So we've just completed the Zero survey in Gauteng, which tries to identify the number of people that have been infected in the past 3 waves. And what we showed is that amongst adults, more than 75% of adults have been infected during the course of the first 3 waves in Gauteng. In addition to which, we've got about 25% of adults that have received at least a single dose of a COVID-19 vaccine. Now, the reason why that is important is that even though this particular variant, Omicron, is likely to be antibody resistant and evasive when it comes to antibody activity, the past infection as well as vaccination also induces another really important arm of the immune system, and that is known as T-cell immunity. And this sort of mutations that primarily occur with a spike protein affects the T-cell immunity much less. And the reason why that is important is because protection against severe disease is primarily related to T-cell immunity. So it's going to be difficult to unpack in a South African situation whether this variant is more virulent than previous variants because there's a different type of immunity that already exists in the majority of the population. Right now, what we see being reported is that most of the cases are mild, and that is true, and there's a number of reasons that could be contributing to that. And one of the possible reasons, again, is unfortunately we're going to see a lot of reinfections. We're going to see a lot of breakthrough infections in people that are vaccinated. But they're going to be protected against severe disease because of this underlying, what I refer to as T-cell immunity that protects really well against severe disease and is less affected by these mutations that predominantly affect the spike protein.
Professor Mellado, coming back to you, from a modelling perspective, we know that this pandemic caught pretty much the entire world off guard. And since it started, there's been very little exact way of predicting how the virus is going to react, how the pandemic is going to behave as it affects different communities across the world. But when we talk about the mutations of the virus itself, have the variants been relatively expected? Is that tracking gotten more advanced over the past 2 years, that we have an idea of predicting what the next mutations are likely going to hold?
Right. So in regard to the type of variant we deal with, we've had to rely on experts that look at the structure of the virus. We basically take information from these experts and analyze the data as it comes. So what we typically do, since nobody is able to tell us when and where new variants are going to show up, is try to react as quickly as possible and address the following question: what is the worst case scenario? Now, as already Professor Madhi has correctly indicated, because we have a very high level of people already infected, we have already reasonable levels of vaccination coverage, it's clear that the severity will be less. We can, of course, speculate, we can have long discussions about the underlying dynamics of that, but the question that policymakers ask is that given the trajectory of the pandemic, given what the limited information we've got, what constitutes a worst case scenario? Now, a worst case scenario in this particular case is to assume that the virulence will be similar as the Delta, the rates of hospitalization will not be very different. If the reality happens to be better, which it appears to be, that's great and fantastic. But the question we have to address is a different one. We don't really address the question as to whether the model has to accommodate the data. The question that we are addressing is is the province ready so that if a peak emerges, do we have enough beds? Do we have enough specialists? Do we have enough types of beds? We also go into the modeling of the hospitalization system, and so on and so forth. So that's the kind of questions we have to really address very dynamically and try to answer them literally within days, because policymakers are under a lot of pressure.
Of course, that's the most pragmatic approach, is trying to plan for the worst case scenario. I think many South Africans are desperate to see some kind of light at the end of the tunnel, and maybe asking, an idealistic question. So, Professor Sanne, this one for you. Is there any likelihood that as the virus continues to mutate, it will become more and more watered down and less virulent? Or am I being naive?
So that is, one of the optimistic views that we like to read about or hear about. The problem is that RNA viruses don't follow those patterns, and indeed they actually become more efficient in their transmission without necessarily reducing the disease risk. And so indeed, it is over time that our immune system needs to catch up. The previous exposure, previous infection is certainly contributing. It does not necessarily lead to complete protection. There is indeed the so-called reinfections that we are monitoring. At this time, it does look like the rate of reinfection has gone up somewhere between 3- and 5-fold, still in very small numbers, but still the reinfection risk is occurring. Anecdotes, because we don't have the numbers really through yet, that reinfection appears to be a mild infection. We therefore don't necessarily have the ability to predict that this virus as a virus becomes weaker, whereas we do in fact see that the immune system will improve with time to in fact deal with the infection. My concern is that the rate of increased of transmission that we're seeing, the rate of number of cases reported each day, appears to really be going very quickly, with today's numbers being in excess of 19,000 new cases across the country, and with incredibly high positivity rates on our testing. And unfortunately, I don't share the optimism of the hospitalization case, because in fact we're seeing a more than doubling of hospital admissions each day, remembering that there is a lag between infection and the eventual hospitalization. And so indeed a lag of about a week. So unfortunately, we do need to prepare our hospitals for surge capacity. We need to look at our oxygen supply chain and be ready to, in fact, address a substantive hospitalization that may occur. Our concern is about the groups that are unvaccinated and perhaps potentially have not yet been exposed. And indeed, that group of people, we don't know the entire overlap between previous exposure and now vaccination, but it could be as large as 40% of the population that has not yet either been vaccinated or had a previous infection with coronavirus up until now. Now multiply the transmission rate that is occurring times the number of people that still can become infected, and a portion of those becoming hospitalized. At this time, we think about 75 to 80% of hospitalizations are in the unvaccinated. And so we have a large pool of people who can still present with overwhelming infection and severe disease. So I do not share the optimism that others have portrayed in the press up until now. We certainly are in for a stormy ride at this time.
Professor, I'm glad you bring vaccinations into the discussion. Professor Madhi, I want to send this question your way. Vaccine hesitancy continues to be a raging debate. There's a lot of finger pointing, there's a lot of emotion involved in discussions around vaccines, especially as government considers mandatory vaccines. But there's one question I want to address head on. Do unvaccinated people allow the virus to mutate in ways so as to be impervious to current vaccines? I don't think Professor Madhi can hear us at this stage. We do know that there is a delay on Skype. Can you hear us, Professor?
I can hear you now, but I missed the question.
The question was, do unvaccinated people allow the virus to mutate in ways so as to be impervious to current vaccinations?
Well, certainly the more people that are unvaccinated, the more likely the virus is to circulate and inadvertently end up infecting people that might shed the virus for a long time, which creates opportunity for the virus to undergo mutations. And that results in this sort of variants. So the more virus that circulates, more people are going to get infected and greater opportunity for the virus to mutate. So without any question, if we were to vaccinate more people, we would be able to dampen the amount of virus that would be circulating. We're not going to eliminate this virus under any stretch of the imagination, but we can reduce the amount of virus that's circulating. And most importantly, is that vaccines are going to be much more foolproof when it comes to protecting against severe disease than taking your chances without being vaccinated.
Right, we're going to continue this discussion when we return with these three experts. We're going to be unpacking some possible scenarios. We're also going to be touching on the very important issue of children under the age of 5 years being hospitalized in large numbers. A lot of people very concerned about that. Do stay with us on eNCA.